important in children, important again in later age. But we will take it that these two were done at different times, and therefore the ultrasound did not show hydronephrosis. Yes, Vinod.
So can anyone among the residents can tell what is the purpose of, we are planning to do urodynamics, but what is the purpose and what is your urodynamic question?
So to know the bladder compliance capacity, to see the urethral pressure profile.
You are telling all the components of urodynamics.
Yes.
The question
in this particular patient, what do you want to see?
So whether any bladder out of suction is there, and or why is having high PVR, to reproduce the symptoms, sir, basically.
No, we don't want vague answers, Kamal. What is your urodynamic question? Why will you do urodynamics in this patient? If you have to have questions in mind. This is what we discussed in last class.
Yes,
so don't just give general things and don't say urethral pressure profilometry here. What is your urodynamic questions? What do you want that test to answer?
So I want to know whether he is having bladder out of suction and what are the compliance of the bladder and what are the detrusor pressure while he is voiding.
Question is very straightforward. It is in singular, question, not questions. You can't have a long answer for this. Would you do a urodynamic study in this patient? If so, what is it you want to know? Simple. You're not going to do UPP and you don't know whether you want compliance or you want to know the bladder. You want to know the obstruction index? You will have to decide on one thing. Why do you want to know the bladder capacity in this man? You've seen his uroflow already. Okay, move on.
So, I think the question that you need to answer is the reflux a consequence of bladder dysfunction? Are the symptoms because of an inherent bladder dysfunction, or are they only because in public he has this problem? Dr. Ganesh, Nitin, anybody, anything to add?
So, Dr. Nitin?
Sorry,
I can't hear you, Nitin. Yeah.
Can you hear me?
Yes, no.
Yes, sir.
Yeah. No, I got disconnected, sorry.
Okay, we'll go on, sir.
Never mind, we'll move on.
So,
Yes, sir.
What is the question that's in your mind now?
Next.
Are we on the same case?
Yeah,
Yes, sir. Same case, sir.
Okay.
Yes, come and tell us what you find, please.
So, in this, I want to know, sir, whether we have done...
No, I'm not asking you what you want to know. I'm telling you, please read this tracing and give us your report on this tracing.
Yes.
You're the boss. We have done the urodynamics. So, the interpretation of this urodynamics pressure as having bladder out of suction
his flow.
We didn't ask you for your conclusion. You have to give us your findings. There's a difference.
Yes, sir. Sir, during the filling phase, the catheters are patent and with
Not a theory answer, Kamal. See, last time, briefly, we had discussed in the last class.
yes, sir.
When we do urodynamics, we want to look at catheter patency, we want to look at the initial pressure before we start filling. We want to adjust the rate of filling according to the question we have in mind. We
Yes,
have to look at what happens during filling. We have to look at sensations. We have to look at the sensation of voiding. And then when the patient voids, we look at different things. Unless you proceed in that systematic manner, you'll gain nothing from looking at this tracing.
So, during the filling,
Is one
with change of with increase in volume, sir, there is no much.
Dr. Nitin is saying something. We'll just give him a minute.
No, I think it is very important. I think what Mohan was trying to stress to you is that there is a very proper way of quoting, standard way of reporting any urodynamic trace. Unless you follow that 1, 2, 3 every time, I think it will be completely, you will no sense. So the initial is to return to your traces and tell me what is at the beginning. Mohan, you don't mind me asking?
No, I want you to.
So look at the trace beginning. What is the problem?
Sir, pressures are above 20, sir, at the starting, sir, at the starting point.
Which pressures
What
are
is the-
about 20?
And this pressure, rectal balloon pressure and the bladder pressure.
So what? The patient could be sitting, patient could be standing.
Sir, we usually set them according to the atmosphere, sir.
Yeah, Nitin, go ahead, Nitin.
So what is missing? What is missing? When we say a good urodynamic trace, what is missing?
So it should be set to 0, sir, either to the surroundings or to the internal pressures.
You never set it to internal pressure. The zeros are always to the atmospheric pressure. Why? Why are the zeros set to atmospheric pressure? Hey, come on, man.
Sorry,
What is that? All of us human beings face what pressure on us?
what, sir? Again?
No, the question, Kamal, is what is the zero with reference to? Which pressure are we equilibrating and making the transducers record a zero? And why are we doing that? Why do we use that particular reference value? Or why that particular reference method?
Anyway, I think so. That's a homework for you.
Yes, sir.
Because I don't believe in spoon feeding. But I will tell you that it is always to the atmospheric pressure, not to internal. So don't do the mistake of using the machine to set to 0. That's number 1. What is the second thing which I would like to look into the trace immediately? Or if I am doing the urodynamics?
So I will see the resting pressure, sir, and I'll ask the patient to cough. And what are the change between the P cycle and P abdomen? Where
is the cough? Where is the cough in the trace?
So it is there, sir. It is showing 33 and 34, sir.
You see, the first cough that at least I can see is well into the filling. Acha, the initial, okay. That's where you're starting. No, I don't think that's a cough.
That's not a cough.
That's not a cough.
What should have happened if there is a good cough? Hello?
Yes, sir.
If there have been a cough command given, what you would have seen?
So, P cycle and P abdomen pressure will increase, sir, simultaneously. If they are not
Is
increasing,
there anywhere in?
yes, sir.
So that means no cough was given. So what does it mean for me, this stress? That you have not even bothered to find out whether the catheters are recording correctly. There is no way I can be sure that what you are recording as the retrousal pressure is a true representation of retrousal pressure because you have not balanced them. So this is the fundamental flaw of this stress, and that is what you have to learn. So if somebody gives me this stress, I said, hey, where is the balance, man? I can't see any.
So I don't think, I think the projection is taking away, there's an overlap of the red and blue line right at the beginning. There is a cough command given where P vesicle.
Yeah, the cough command it is given at the beginning.
Yes, sir.
And then
It has to be given at a periodic interval, and most importantly, it must be given after the voiding is finished. Once the voiding pressures have been recorded, the voiding has finished, you must give another command of cough to make sure that you still remain balanced. So I think it is very important to follow the good urodynamic practices to make it something which is it will stand scrutiny anytime. So anyway, that's fine. Go ahead.
What else do you find here? I mean, you have so many leads and you have so many tracings. Can you identify them and tell us what each one represents, please?
Yes, sir. The P cycle represents as a bladder pressure, sir, and
The
abdomen.
intravesical pressure. Use specific terms.
And
Okay.
so this rectal balloon, which represents the abdomen pressure, and the PDAT represents the detrusor pressure, sir.
How are they measuring detrusor pressure?
By subtracting the, sir.
No, it doesn't represent anything. PDAT is a derived pressure tracing.
Yes.
Okay.
Then EMG leads, sir, are there. There are two types of leads, one a needle and one is the.
No, in this tracing, forget about that. We'll come to all that maybe at another session. In this tracing, what does the EMG show?
So EMG represents the, sir, pressure in the pelvic floor, sir.
Pressure in the pelvic floor?
Or represents the sphincter pressure, sir.
Pressure? It's a myogram, electromyogram. Plenty to catch up on, Kamal.
Yes.
Kamal, spend whatever time you have in the urodynamics room.
You have to, without this, when you get a tracing of this kind or any kind, you'll be doing all the wrong things by the patient.
Okay, now first tell me how would you what are your findings? How you talk to how you actually write it? If you are writing a report of this urodynamic trace, what would you write?
We'll ask Praveen to answer that, sir.
Yeah, sure.
Sir, I would like to start with urodynamic indication, sir, and the antibiotic which is given and the catheter which we have used for.
Does antibiotic make a difference to the tracing?
No, sir, not for tracing, sir. But
Then why do you want it? In a urodynamic report, it
Yes,
should have the reasons for doing the study, the question that you've got, how you've done the study, what you've found, and what your conclusion is.
Yes, sir.
Will you follow that sequence and tell us, please?
Yes, sir.
Praveen,
Yes, sir.
you bought a question. What is the evidence for using antibiotic for every patient who is undergoing urodynamics?
Sir, not on every patient, sir. The patient who are on high risk for urinary tract infection, we are using antibiotics, sir.
You said you write about antibiotic as if everybody needs to get an antibiotic. That's not true.
Yes, sir.
Yeah. Then
Sir,
how would all that you have done now? What do you report? How do you report? What do you
Sir.
see before you start?
Sir, I will start with filling phase reporting, sir. Sir, I will start with rate of.
Praveen, patient has come to you. You are the person in urodynamic room.
Yes,
You
sir.
may not have seen the patient. Okay.
Yes, sir.
Now the patient has been presumably sent here to rule out primary bladder neck obstruction. That's maybe. I mean, I'm just saying. Maybe that he has been referred by the clinician saying query bladder outlet obstruction.
Yes, sir.
Now he comes to you. So before you start urodynamics, what are the things you look for?
Sir, I would like to look at his clinical records, sir, before history and examination findings, which are taken, and I would start the.
Praveen, I have referred the patient to you with this clinical record. Query BOO, advise urodynamics. That's all there is.
Yes, sir.
So, Dr. Nitin's question, how will you begin? What will you begin with? Or will you step into the room after the catheters have been placed?
I will ask the patient if there is any additional symptoms which were.
I have not written any symptoms. I have only written query BOO.
Yes, sir.
As a referral center, this is probably what you'll be getting. Somebody will refer saying query BOO, advise urodynamics.
I mean, we look back. You were there when he was presenting the earlier slides.
Yes, sir. I was there, sir.
You were there. So, if suppose the patient has been referred to you with those kind of instead of a slide of a reference, saying he came to with these symptoms and his flow is 15 mils per second, whatever the flow was. It was 15, I guess. How much was the free flow?
34 peak.
34 peaks, sir.
I mean, was it without an artifact 34?
Yeah. It was a bell curve, Nitin.
Yeah, because each one is 10, is it?
Yeah.
Or 5?
25. The middle one is 25, sir. 12.5, 25, 75.
5 ml.
Sorry?
It's
So
5
it's flow.
ml.
So it is 5, 10 and about 13 to 14 ml per second is his flow. And you are the person who has this flow is available. What would you do?
See, you have this machine in your hospital.
Yes, sir.
Have you looked at what the graph is? There is something known as range. At what range is the graph fixed? What does each of the large squares represent?
So 12.5 ml per second, sir.
Arey Baba, what does the graph represent? Is it 10 ml per line? Is it 20 ml? Is it 5 ml? Is it 1 ml?
12.5 ml. Sir, vertical axis is 12.5, sir.
How do you know?
Sir, it is maximum, it is written 50, sir, in the top.
In the top, it is written 50. It is 50 at the top. So
Yes,
how
sir.
many lines do you have till the top?
4, sir.
Where do you start the zero from?
0 from here, sir. So 0 is here, sir.
Okay.
This is 15.
Okay.
1, 2, 3, and 4 lines, sir.
Okay.
It's slightly unusual to have this kind of a thing.
I'm going to say that.
There is
Have
absolutely no
you read about good urodynamic practice? About what is the range that has to be represented in a graph? See, one can compress, one can decompress and get all kinds of configurations. And we've discussed repeatedly in uroflowmetry, the graph or the tracing is as important as the values. That is why this has been standardized, that any standardized equipment will represent these many ml per minute at this
See,
time.
most of the time the division is either 5 or 10. So it depends on what is your scale you are using, either it is a 5 ml or a 10 ml. So that is very important to know. The question which I was driving point was when I think I went off the thing, that the way this patient was evaluated, it usually will not make sense to us unless some information is there which we didn't know. Whether looking at this flow, how many people would first immediately make a diagnosis of bladder outlet obstruction?
So the urodynamic question which I want to know is that his symptoms are not correlating with his investigative findings. So
what is not correlating?
He's got poor stream. He can't pass freely in public. He says it takes a long time.
No, he says that. But did you objectively document poor flow? Your flow is normal. Is that right or wrong?
Yes, sir. But uroflow can be sometimes it may be misleading.
Sorry, I can't get that.
Uroflowmetry can be misleading at times, sir. And in ultrasound there is significant post-wide residue.
Hang on. We're talking only about the flow. See, you have to learn to interpret flow. That's what we are trying to get you to do here. Based on this flow, the rates in the graph, how many people would think this is bladder outflow obstruction? That was the question.
It is very less likely, sir. I would not think.
Not. You have an ultrasound which shows the upper tracts normal, correct?
Yes, sir.
So upper tracts normal, flow normal. How many patients like this you will be subjecting them to urodynamics? Just because they say that my flow is not.
So if the post-wide residue was not significant, I would not have gone further with MCU and RGU also.
How many times have you done the assessment of post-wide residue?
Every time we do, sir.
In this study, how many times have you done it?
So I'll just take Praveen out of his predicaments. So ideally, I think at least 2 or maybe 3 times it should be done. And in this patient, the sequence of events, like we said, so we have sort of compressed the history a little too small. He was subjected to a bladder diary, bowel was sorted out, and he was subjected to conservative management. When all that did not help him, only then we went on to urodynamics.
No. But Manish, we are not questioning the way this patient has been evaluated by you or anybody. The point of my questioning is for these guys to understand that how they have to think.
Yes, sir.
My issue is I'm not happy the way he is thinking. So that is the point I want to bring out, that many times there is an issue of so-called post-wide residue. You don't even ask the patient how long he waited for his residue in many setups, unless you are doing it immediately. And then it brings a very important point, that why should a residue be high in a patient who is voiding with a good flow? And that is the question we must start ringing in the mind to say, why is that? Is there something else going on here? Rather than just an obstruction. Because a young man, even with a bladder neck, it's not easy to get such a high residues, especially with upper tracts normal. So all these things, they must think. If something comes in the examination, it is a surprise. It is not usual. That is what I am trying to say. It is very difficult to believe that somebody will generate a residue of persistent 200 ml for so many years and has had no effect on upper tract. It's very difficult. So, and the thing which I wanted to ask him is that the patient comes to urodynamic suite What are the things he looked for, which you already answered? That he should have said, I would look at his free flow, review his free flow. I would look at his voiding diary so that it gives me an idea. Why, Praveen, why do you want to look at a voiding diary?
Sir, to look at the voiding volume, sir, and he has voided
Voiding
only 100 ml in the ultrasound, sir, and but in the uroflowmetry he has voided 272 ml with good flow.
Yeah, so that itself gives you a lot of answers, isn't it?
Yes, sir.
And a flow, if not done the way it should be done, to the useless investigation. Same thing about urodynamics. If you do a urodynamics like that, it is a useless investigation. So the voiding diary properly maintained gives you a lot of information. So what are the main thing you are looking for in that voiding diary?
So voiding diary, that amount of fluid intake he is taking, sir, and how many times he is having urgency, and if there is any urge leak documented, and the voiding volumes, and nocturnal.
I'm asking the question of voiding diary in context to the study which you are going to perform. The clinician has seen his voiding diary and has realized that there is no urgency, nothing, no or activity, and he has sent you with a query saying PBNO. So when I am starting the urodynamics, what is the value of the voiding diary for me?
Voiding volume, sir. Maximum voided volume.
Yeah, so what does that give you? What is the word used for that?
So that is the clinical bladder capacity, which we can come to now.
Not clinical, it's conscious bladder capacity.
Functional bladder. Yes, sir.
Clinical, where is this word? Have you ever read this
No, sir.
word, clinical bladder capacity? Yeah, I'm very sticker about terminology, unfortunately. So you should be very clear what you're doing. So how does that help?
So that helps us to determine how much filling we have to do, sir.
Yeah, so it's so important.
Anything else, Praveen? One is, of course, how much you will fill. Anything else that will help you, that it will help you determine?
Frequency, sir?
No. If you know the functional bladder capacity is this much, you will know how much to fill to make it physiological filling, agreed.
Yes,
Will any other aspect of the urodynamic study be determined by this, the functional bladder volume? Or is it only the filling capacity or the filling limit?
If the volume is less, it can be because of detrusor overactivity.
No, I'm asking you, understand? Volume.
Yes, sir.
You have got
and
filling a certain rate. Volume.
Filling rate we have to discuss.
Sorry?
Filling rate, sir. Rate of filling.
So two things. One, how much to fill and at what rate to fill. Okay, so it's not just about how much, it's also about at what rate to fill. This again is standardized. So you want to know that.
Yes, sir.
Okay, next up. So now tell me how you describe your trace.
Sir, at zero filling, sir, the cough, the patient has coughed, and both the graphs are synchronous, and the detrusor pressure at filling is zero, sir. And as the filling increases, the bladder pressure, the P rate is increasing, sir.
That is the way. Is that the way you report a urodynamic trace?
No, sir. The first sensation we have to see, sir. And periodic
sensation or pressure.
What is your filling speed?
Filling speed in this graph, I'm not able to make out, sir.
Filling by gravity method or filling using pump, filling rate, initial pressure this much, started filling at this rate.
So in this graph, I'm not able to make out the filling rate, sir. 10 ml.
You can actually, but we'll let it be.
What is the filling rate you use?
So 10 ml per second.
Everybody use 10 ml.
See, if you use 10 ml filling pressure, filling rate, Your study will go on for a long time. The patient gets impatient. He cannot sit or he cannot lie down or stand for such a long time. And you've got 8 other patients waiting for the day. What are the ICS defined filling rates? What are the filling protocols?
So based on the bladder capacity, it has to be divided by 10. So,
What are the filling protocols?
so slow filling, medium filling, and fast filling.
And rapid filling, right?
Yes, sir.
Slow fill, medium fill, rapid fill. So what is slow fill? What is medium fill? What is rapid fill?
Slow fill is 5 ml per second, sir.
Is that how it's described? I think again you should read. I mean, shooting from the hip is all right if you know everything. You have to read.
Yes, sir.
Okay,
So you write at the beginning that you are filling with normal saline at room temperature. The filling rate is say this ml per second. At the start of the thing, the transducers were 0 to atmosphere. Subsequent coughs, check the balancing that all the lines are well balanced. And then your filling was started at the rate of this. And then what do you report?
The first sensation.
Okay, so you say first sensation of patient was reported this ml. Then?
And if there is any urge patient experience after the first sensation, sir. And if in this graph, there is no.
If he has urge, then it is not the first sensation. You don't mark it as first sensation.
After the first sensation, patient may have urge, sir.
In a normal tracing, what is it called? What does it signify in the patient's awareness of bladder filling? It is the volume at which the patient senses that there is urine in the bladder.
Yes, sir.
If the patient has urge, that is a different sensation altogether. Which means we'll have to now ask you about what is urge.
So the sudden compelling desire to void.
Does the patient get that at first sensation?
No, sir.
If he gets it at first sensation, or if that is the first sensation you elicit, is it normal or abnormal?
It is abnormal, sir.
When is it normal? Or when do you say that urge is at normal volume? So let's not go into that. So the first sensation is when the patient first senses there is some urine in the bladder.
Yes, sir.
Okay. So what do you note at that point?
So the volume, filled volume, I want to note, sir.
Anything else you note?
And pressure.
And pressure. And anything else, since you got this extensive tracing, anything else you want to note?
Sir, at that point, what is the electromyogram activity, sir, if there is any compensation or not?
It's not called compensation, there is any contraction.
Yes, sir.
There is increased EMG activity.
Yes, sir.
Okay. Right?
Sir,
You are a great believer in EMG.
Sir?
You look at that trace and you tell me whether you should believe it.
Is it your practice to trust EMG tracings recorded during a routine urodynamic procedure and use that in your decision making?
Yes, sir.
Is it validated enough to help you, or is it a poor witness?
Sir, it is a poor this marker, sir. But if it is consistently present in 2 to 3 studies, then clinically also we have to correlate, sir. If it is fitting the clinical picture, what we are thinking.
So Dr. Nitin asked you, are you a believer or a non-believer?
Yes, sir. We usually take it also into consideration, sir.
You know, do you believe that it has to be taken into consideration?
Yes, sir.
Praveen, in which situation does the EMG become important in a CMG trace? I mean, you've got the EMG in front of you, but as Nitin says, you may not believe in it or you believe in it. But what's
Yes,
the best way of believing in it?
Stress leaks, sorry, in the situation of stress urinary incontinence, we have to.
The EMG trace.
In which kind of bladder dysfunction would EMG have the greatest weight? In which type?
In filling cystometry, it is
In which type of bladder dysfunction, clinical type of bladder dysfunction, would the EMG have the highest weightage?
the neurogenic bladder, sir.
Arey Baba, how many times have we told you don't use the term? It doesn't mean anything.
So detrusor sphincter dyssynergia.
So if there is suspicion of detrusor external sphincter dyssynergia, you may find it useful. Correct?
Yes, sir.
So there is a school of thought which believes that an EMG tracing, which is open to so many errors of recording and interpretation, is not necessary for most urodynamic diagnosis. And
Yes.
if an EMG is being recorded to document detrusor sphincter dyssynergia, then it must be part of a video urodynamic study.
That's very important. If you have to give credence to that test, then you must do it with video.
Yes, sir.
That's what Dr. Nitin was trying to ask you, that how much value do you place on your urodynamic traces with your EMG collaboration?
Okay, sir.
So now, what is the parameter you report?
Sir?
So we went down the first sensation. After that, what else you report in filling phase?
The first desire to void, sir.
Okay.
And strong desire to void, and at that point we will stop the filling and we'll record the urodynamic bladder capacity, sir.
Do you note anything else on the trace when the patient says, I have a strong desire to void?
So we will stop the
Notice anything else on the trace?
So we'll stop the filling for some time and see if
Stop the filling, but will you notice anything else on the trace? And the patient says a very strong desire to void.
How do you differentiate between urge and a desire to void, a true desire to void? When
Sir,
you're recording the urodynamic tracing,
yes, sir.
if a patient says, no, I have to void urine, how do you differentiate between a sensation of urge only and a true desire to void?
So that if we would have done a bladder diary before that, sir. If it is approaching the function.
What do you notice on the trace at that point?
On the green line, what do you see?
It's a pressure being raised, sir.
Right? You will see normally pressure going up.
No, sir.
What will you see? That's what.
Detrusor overactivity will be there, sir.
Overactivity.
In case of urge.
Why should there be overactivity when the bladder is full? When the patient wants to void?
So don't know, sir.
Does anything happen in the bladder to indicate that it's filled and voiding is imminent? The basic bladder physics. Have you heard of the phases of bladder contraction? No, I think you guys have to do a lot of reading. You've been treating this very lightly. Just because somebody sends you a tracing with some report written on it, you've neglected bladder physiology and urodynamic physiology completely. See, there is a phase.
Urodynamic traces in human.
Sorry?
Who does the urodynamic tracing in the studies in NU?
The urodynamics nurse.
Sorry? urodynamic nurse. Now, this
Yes,
is a big problem, you know. Even in our place, the guy who does the urodynamics knows much more urodynamics than most of the consultants because he's so good. And this is where the biggest problem is. I think the residents have to, only when they start doing these tests and understanding why the test is being done, that these questions will be answered. You look at the test and you decide. But if you leave it to a nurse or to some technician to do it, then it's a big problem. We all learned urodynamics by doing it ourselves. No nurse did it. That's why Nitin asked this question as to what will you do when you see the patient first? You don't just do the test. You look at the history, you try to find out from the diary, you look at the free flow rate, you look at the PVR, you look at it. You're a urologist. You're not a technician doing this test. That's the only way you learn it.
Nitin, can we move on so that we can take up one more case? Shall we? What his conclusion is?
No, I just wanted him to, because what Dr. Ganesh has said, that will come through only when you do the test and write your report, so that you are, like, for example, he should have mentioned that with each cough, I would have seen that the balance remains correct, that there is no provoked detrusor or activity, or if there is anything, any other contraction seen, was it associated with anything? And then he should tell us the capacity and the end filling pressure. These are the various things. Then you say, I voided on command, then because at the beginning you should have said which position you are doing urodynamics. If you are standing, no problem, but you need to tell us that he voided in standing. If you suppose you filled him in a different position, did you balance the transducers again? All these things will make a difference to the quality of reporting and tracing. And then you obviously report the detrusor pressure, the maximum detrusor pressure, the P-rated Qmax, and the at the end of the micturition, following that, again a cough command to make sure that that is what will constitute as a good urodynamic tracing and a good reporting. And every time you practice this, every patient you do this, you'll pick up artifacts. That is the only way you will learn how to differentiate an artifact. So that is the reason I wanted to stress, basically, for them to understand. But I didn't know that they don't do urodynamics, because I think that is basic. You should at least put them to do few aerodynamics, not like that, because otherwise there is a black and white trace which will make no sense. Go ahead, Mohan.
The only way they will do a urodynamics is if we handcuff them. So we've tried everything. Doesn't work.
And stop giving them operation, they will do.
Yes, sir. First years, we'll follow that.
Yeah, just say, okay, fine, don't do urodynamic, don't get cases to do. Finished or done. How can you not discipline these guys?
Exams. More, put it in the exam. Instead of doing cystoscopy like those days, you do a urodynamic trace.
We go to the next case, sir.
Yeah, I still want money.
No, Nitin, go on.
Yes, sir. Yes, sir.
No, the question which I had started asking this boy was that suppose somebody has a good flow and has a residue, how would he explain?
What is the first question you will ask when you see that?
Sir, was it his normal voiding? How he usually voids?
Okay.
He's voiding with 28 ml flow, young man, no neurological problems, upper tracts normal, and somebody reports persistent residue.
Yes, that whether it was his usual void or not, sir, and whether he has taken any excessive fluids just before ultrasound, just for the sake of ultrasound, and the duration between the voiding and the post-void residue recording, I would ask, sir.
No, all that is fine. You yourself did it. You did the flow was fantastic, and you did the thing, oh, that is 150 residue.
How do you explain the good curve with the high residue? How can you explain how will the good curve come in with high residue? How is the flow being compensated?
So by detrusor compensation, sir.
Detrusor compensation. Yeah, I don't understand it. So please explain. What is detrusor?
Here, Praveen,
Yes, sir.
You look at the voiding phase, you see what's happening. It is called augmentation. You see how the voiding is taking place.
Sir, in voiding phase, the detrusor pressure is very high, sir, but the sphincter is not relaxing. EMG activity
Look
is
at the
also
sphincter. What's happening to the red line?
there. A lot of abdominal straining is also there.
No, that's not really. It is well subtracted.
It's, why has it suddenly gone up? It has climbed to the first floor. Why?
Is also using abdominal valve to void. Abdominal valve.
Abdominal valve.
Valsalva voiding. So.
Valsalva voiding. What will you get in a Valsalva voiding? Is it an abrupt increase in abdominal pressure, or is it a gradual increase, or is it a sustained increase? What do we get? See, that's why, don't just come out with terminology without understanding what it means. Here you find that the abdominal pressure has remained high throughout the phase of voiding, and it comes down only when the detrusor pressure also has come down.
Yes, sir.
You see that? Why has that happened?
So are you telling me, Praveen, that everybody who voids, normally that is abdominal pressure becomes zero?
No, sir.
Then why are you so surprised that the abdominal pressure also goes up with voiding? Is it a smooth voiding, smooth pressure going up, or it is a straining pressure going up?
It's a smooth pressure, sir.
Yeah, so that's why you have subtraction.
Yes, sir.
And the subtracted detrusor pressure is how much?
It is.
What is the P?
So more than 408, 428.
408 is a volume, Baba.
No, sir, this one, 408.
Yeah, that's a volume.
More than 100. Volume is 3.4.
And where is the flow line?
Flow is.
It's used to the voiding graph. Next graph.
Where is the flow?
This is the
Expanded graph.
Where is the flow?
I am not able to see the
Flow curve is here, sir. It is very small flow.
There's hardly anything.
Yes, sir.
Is it matched he has produced? You have a free flow from him.
Yes, sir.
So
It is not matching with the free flow uroflowmetry, sir.
So what is the value of a urodynamic trace which does not match his original flow, which is done in a free fashion?
It cannot be taken into consideration.
So this urodynamic trace makes no meaning for me, because it is just not representing what he does outside the lab. So what is happening in this lab, as far as I am concerned, is completely artifactual.
You think the lines are causing obstruction, man? Praveen?
Sir?
Those two lines, you think they are causing an obstruction? Inside.
the urodynamic catheters.
You think that?
No, sir. It doesn't cause obstruction, sir. But the sensation would have made the patient anxious, and he might not have voided normally how we use voided.
Praveen, understand the question. Can the standard urodynamic catheters produce an obstruction and create an artifact in the voiding systometrogram?
No, sir.
How do we explain this then? So you see, this is where everything in the beginning becomes important. What is the caliber of the lines that you have used? Is it single lumen? Is it double lumen? Is it triple lumen? Right?
Is it two
And
feeding
then-
tubes? Is it two feeding tubes?
No, sir. Single catheter, sir.
No, you would have used two, isn't it?
No, sir.
One for filling and
We
one
will
for
use
pouring.
only double lumen single catheter, sir.
Yeah, so you've used a double lumen catheter,
Yes, sir.
right?
Yes, sir. 5 French we are using.
You- 5 French. I don't think you've even seen the catheter.
Double lumen will be possible in 5 French. It's a great design.
Your flow will be one drop at a time, then. That pump might start giving trouble. It may backfire on you.
Manish,
Yes, sir.
are you getting special manufacturers?
No, sir.
Then send it to us also.
Nitin, you should ask them to spare you the trouble.
Anyway, what my point was making to this thing was that any urodynamic study which does not match normal investigation had to be taken with not pinch but a bag of salt. There's something wrong. And so I think we'll have to leave it at that, but that's fine. That the observation must be made. So if I'm writing this report, I would say I will repeat the study, of course, by explaining the patient that, you avoided so well, what's gone wrong, or where something wrong happened with the flow meter recording. So I think that is what it is, and it looks like as if he would have, and a video here would have been far more helpful than this EMG, which makes no sense. It's one of the most useless investigation I personally feel in most of the situations, especially when you use surface electrodes. It makes no sense. It has so many artifacts that there is nothing you can actually deduce from it. And simple video would have given you all the information, what is happening. Why didn't he open his bladder neck that day? That you could not even produce a flow. While he is producing a flow which is more than 30 ml, it just doesn't match. So I think it is important to note all these differences and not just blindly say he's got primary bladder neck obstruction or whatever. So that's the point.
And for clinical completion, if it did not void with the catheters in situ, I would have removed the catheters and asked him to do a uroflowmetry. Void normally. That again would have told us whether it was the catheters and the environment in which he was that was a problem, or whether he genuinely had bladder dysfunction. Well, this entire sequence has to be gone through. Patient enters, get him to do a free flow, check the residue immediately before you insert the catheters. Insert the catheters. If you believe in it, aspirate and see what the residue is. Then neutralize the pressures. Then connect the filling lines. Get the transducers going. Start the filling. There are variations in rates of filling which are good to practice depending on what you find initially. See if there is any contraction during filling. If there is a detrusor contraction during filling, see at what volume, see whether it is accompanied by a sensation. Quite often these detrusor contractions go unnoticed. And then see how it proceeds. When the patient says he's got a strong urge, see whether the patient can postpone the urge. If the patient can postpone the urge, see at what pressure and volume he says, no, I have to void urine. Then get him to void urine. After voiding urine, if you find that is not voided at all, take the lines out, make him go through a uroflowmetry, see whether he is able to void then. For two reasons. One is to know whether you were unable to replicate. And second, he might have gone into retention because of the procedure. So you can't send him away if he is in retention. That would be the gamut of activities while during a urodynamic study. There is a pre-study protocol, there is a study protocol, there is a post-study protocol, all of which are important. And Dr. Nitin has highlighted so many points in the way urodynamics is done.
So returning back to my original question about the residue, still not answered. Hello?
Sir, according to MCU, he is having grade 3 reflux, sir.
Forget about the FQ, that you did later. I am asking you, if you are in a clinics and this situation happens, how your mind starts working? That's what more important to me.
You did a flow
What is that
metry, you send him for ultrasound, and then he comes
What is
back
that?
with this high residue.
What is the term paradoxical residue means? Hello?
Sir,
He's thinking.
For free.
I think, that's why, the people don't like us.
don't know, sir.
Mohan, they don't want us to come here any training or teaching today. Yes, sir.
I'm back in the unfortunate situation of being with you. And they have me every week.
Yeah.
No, let's have some takeaways from this. First, if you find a high residue on ultrasound with somebody who's voided normally, that's the point at which we have to think, why is this happening? And check for the accuracy of our residue estimation. Only if we are sure that the residue is a true residue, then we look at what could be the causes. Now, he said something, Dr. Nitin referred to something, some form of residue, right? So if this is due to the reflux and is coming back, then I would rather do an MCU first and not a urodynamics. But in the presence of normal upper tracts and ultrasound, a grade 3 reflux or a reflux of a volume large enough to push back 160 ml into the bladder is unthinkable.
So what is the other possibility?
Yeah, sorry, go on.
Sir, there can be bladder diverticulum, sir, which is missed on the imaging.
Yeah, it is missed. Many times a large amount of diverticulum can be missed on ultrasound because it's very difficult. It just becomes a part of the bladder. So that is the question I had at the beginning, that just don't subject everybody to straight away urodynamics. The basic urological evaluation must be complete before you take patient urodynamics. That's the point I would like to drive. That you never get any extra information from urodynamics unless your basic urological workup is sound. Otherwise, you will make mistakes. So that's the most important thing I would say. So we can proceed to the next, no problem.
Yeah, one last question, Praveen. Can this entire urodynamic finding be explained by the presence of a large diverticulum? Think about it. All of you can think about it and tell us before the start of the next session. I will move on to the next case.